my name is Jamita Rollins, and I would like to thank you for coming to the session. I'm honored to be co-hosting this session of International IVF Initiative. For videos of previous sessions, please go to ivfmeeting.com, and don't forget to leave a review. I encourage you all to ask your questions using the Q&A section of the conference service and not on the chat function. My name is Jamita again, and it is a great honor to be co-moderating this session with Dr. Sangita Jindal. I'm honored, truly. Dr. Jindal earned her PhD in physiology from the University of Toronto and became a high complexity laboratory director in 1997. Dr. Jindal has served on the faculty for New Jersey Medical School Rutgers, and for the last 20 years have been on the faculty for Albert Einstein College of Medicine in New York as associate professor and laboratory director in the Department of Obstetrics and Gynecology and Women's Health. Dr. Jindal currently serves on the executive board of SRBT and on the practice committee of the American Society for Reproductive Medicine, among other leadership roles. She's a member of the editorial boards of Fertility and Sterility Reviews and the Journal of Assisted Reproduction and Genetics, and is a reviewer for the Human Reproduction, Fertility, and Sterility. See more of her impressive bio on the website.
That's very kind of you, Jamita. Thank you so much. I'm very pleased to be co-hosting this session with you. And now it's my turn to introduce you. You're an andrologist at RBA. That's in Atlanta, yes? You've relocated? Yeah, with over 6 years of lab experience, but you're a native New Yorker who relocated to Atlanta to complete your post-bac in clinical lab science at Emory, which you did about 6 or 7 years ago. And you received your lab license as well as 2 academic scholarships from the American Society for Clinical Pathology. You also hold your Bachelor's of Science degree in Biomedical Technology from Long Island, LIU, Long Island University, and your Master's in Reproductive Clinical Sciences from EVMS. During your graduate studies, your research interest included intrauterine or IUI inseminations, and your research focused on utilizing pentoxyphylline to increase sperm motility of cryopreserved specimens for IUI. And again, see more of her impressive bio on the website. This session is entitled The Book of IUI, and we shall focus on that now and have an introduction by Jamita. Thank you, Jamita. Take it away.
Thank you. Okay, so my introduction is entitled, Is IUI Art? Now, art, not drawing, but assisted reproductive technology. My disclosure is I have nothing to disclose, but I found this picture and it kind of looks like molecules, even though they're people, so I thought that was pretty cool.
Jamita, you'll have to share your slides again. If you want to do it again, yeah? We can't see your slides.
Okay, let's see. Can you see now?
No.
Okay. Hold on 1 second.
No problem. These things happen.
Can you see it now?
I can't.
Oh, I know why. I forgot to share my screen. Okay.
That looks promising.
Okay. Are we good now?
Looks great.
Perfect. All right, let's rewind. Hi again, my name is Jamita, and I will be doing the introduction called Is IUI Art? Art, not drawing, but assisted reproductive technology. My disclosure is that I have nothing to disclose, but I found this picture and I thought that they look like molecules, even though that they're people, like skydiving, I think. Okay, so how it all began. AI for Humans was an adaptation from a dairy milk farmer study. The farmer's goal was to improve milk production by using AI with specially selected sperm. The first human AI was performed by John Hunter in 1790. He instructed the patient to collect semen in a warm syringe that was then injected into the vagina. This resulted in a positive pregnancy. Here are some important milestones in AI. In the mid-1800s, J. Sims performed 55 inseminations. Only one resulted in pregnancy. Interesting thought, he believed that ovulation occurred during menstruation. So that was probably the reason why only one pregnancy occurred. In 1890, sperm extenders were introduced. In 1941, egg yolk media with sodium citrate was a precursor to sperm freezing. In 1949, the first sperm freeze occurred. In 1953, the first successful AI pregnancy with frozen sperm was successful. In 1970, sperm banking became commercialized. And in 1978, as we all know, the first baby was born from IVF. So, is AI popular? AI became interesting after sperm washing was introduced for IVF in its early years of IVF. The efficacy of AI is also controversial. Should we do AI or should we go straight to IVF or ICSI? When thinking about these questions, it's important to remember that AI is common treatment for LGBTQ and single women. Here's a map of some main ART regulatory agencies all over the globe. Most are associated with the International Federation of Fertility Societies, or IFFS. IFFS is a non-state actor that promote and develop educational initiatives in the field of reproductive health in support of the World Health Organization. Here's a list of some more global regulatory bodies that are part of the AFFS. I know what you're wondering. There are 55 affiliate organizations. So with 55 plus global art agencies, where's the IUI data? It is common knowledge that IUI success rate tracking leaves more to be desired. I was interested in understanding globally, where do they track IUI rates? Come to find out, the IUI data is only officially tracked in Europe by the European IVF Monitoring Consortium. The EIM is an established group of national registries of assisted reproductive technology whom collect data. They began collecting IUI data in 2002. Sorry. With this knowledge, I searched deeper to get a better understanding of European IUI legislation. In Europe, 44 countries perform IUI and IVF. Of those 44, only 33 provide specific legislation and public funding. 35 European countries consider IUI art technique. And as you can see from this table, that although there are 44 countries, only 18 of those countries allow ART for LGBTQ females. And in 5 countries, IUI is permitted for patients of all demographic groups. So again, is IUI art? The ESTRA website provides this interactive resource where ART and IUI treatment legislation are explained for European countries. Listed are the countries that consider IUI an art procedure. IUI is considered an ART procedure in Cyprus, Czech Republic, Greece, Ireland, Macedonia, Netherlands, Romania, Russia, Ukraine, and the United Kingdom. Because of different global legislation, fertility tourism has become a popular practice to mitigate treatment restrictions. Fertility medical tourism is common in Europe and Asia, with patients traveling far from their home to access fertility treatment. Health tourism is a website that lists tourism countries for specific medical treatment, including fertility. As you can see, the popular IUI countries are Europe and Asia. questions that need answers. So I've spoken about IUI ideologies globally and its regulations in regards to its consideration as ART, but what about clinically? Here are some questions that I would like you to think about throughout the webinar. Who should perform IUIs? How to use IUIs? What is the correlation between the LH surge and insemination time for best outcome? Medicated versus unmedicated. How does semen processing affect IUI outcomes? Fresh or frozen, does one yield a higher positive pregnancy outcome? Does the use of extenders and pre-seed support IUI outcomes? Would the addition of additives to increase sperm motility aid for better IUI outcomes? And most importantly, is IUI art? Dum, dum, dum. And now I would like to present, now I would like to stop sharing my screen so we can present our first presenter.
Yes, thank you so much, Jermita, for that introduction. And I would like to introduce our first speaker, Professor Willem Oombelet. Willem Oombelet started his career researching infertility and IVF in 1984 in Pretoria, South Africa. In 1998, he obtained his PhD degree at the University of Leuven on the value of sperm morphology and other semen parameters in diagnosis and treatment of human subfertility. From 2001 through 2004, he was the president of the Belgian Society of Obstetrics and Gynecology. Willem Oombelet has authored 180 international peer-reviewed articles and was an editor or co-editor of 21 books. Amazing. He has received 2 international awards. He is the founder of the Genk Institute for Fertility Technology and the Walking Egg nonprofit organization. He's a past coordinator of the ESHRA special interest groups on global and sociocultural aspects of infertility and andrology. He's the editor-in-chief of the international scientific journal Fact, Views, and Vision in OBGYN, and he is the chairman-elect of the ESHRA special interest groups. I'm very pleased to invite Dr. Willem Oombelet to present his work.
Thank you so much for a nice introduction. I'm very pleased that you asked me to give a talk on one of my favorites, of course, intrauterine insemination. I don't have a disclosure to tell you. I'm only the chairman of the Walking Egg and a bit linked to ESHRA, but that's all. First of all, for those who are already for a long time in the field, there are always believers and non-believers for IUI. I did my first study on IUI in '85, and from the first moment on, there was some non-belief, it doesn't work and so on. Then there was a ESHRA Capri workshop group in 2009. I will talk about it right now. And then, of course, there was the story in England that they didn't allow us to do IUI anymore for unexplained male factor infertility, which was quite a story because we didn't expect that at that time. The conclusion of the group in Capri was the following. At that time, there was a high multiple pregnancy rate, and they were a bit afraid of that, and for good reasons, I think. But it was more often seen in the United States and in Europe. And they asked us people to have more trials needed for IUI to convince people that it's really a good treatment option. But the problem is that in those years, and I'm talking about the 90s and the 2000s, there was almost no interest of the pharmaceutical industry. Limited number of sponsored studies, all the energy and the money went to IVF. The IVF centers didn't have a lot of interest in IUI for obvious reasons. And IUI was mostly performed in first-line practices, not in the big IVF centers. And they didn't have a lot of interest and experience in organizing randomized trials. This was one of the problems in the IUI world. But then all of a sudden, and I was very happy about that, thanks to the Dutchman, they organized a multicentric prospective study, and they compared 3 IUIs compared to 1 IVF with single embryo transfer and IVF with modified natural cycle. And I know from the beginning, they performed that study to convince people that IUI was useless. Lucky for us, the conclusion of the study was different. And there was another study of the group of New Zealand, Farquhar and co-workers, and they proved only a few years ago, which was written in the Lancet, that intrauterine insemination with clomiphene citrate is better compared to expected management in case of unexplained infertility. These were the results of the Dutch study, and you see they expected less success for the intrauterine insemination, but also they did expect much more multiples, and the multiple pregnancy rate was equal in the three groups. It was a bit of an exceptionally conclusion at that moment. And then in the same group of patients and the same group, they found out that from a cost-benefit point of view, IUI is more, it's much better option to do as a first-line treatment in case of moderate male infertility and unexplained infertility. But get it right, there are different success rates. If you look at France, actually, but the same in Belgium, the same all over the world, the different centers have different success rates for many reasons. And it goes from 4% to 90% per cycle in France. In X-ray registry, they found even in 2011 between 1.3 and 14%. But even in Belgium, we see that some centers have 2% success, some centers have 14, 15% success. This, we have a problem. And then Ben Colen and myself, we wrote a book about a few years ago with a lot of experts. We wanted to show the world that there is some evidence in performing IUI as a first-line treatment in some cases of infertility. And perhaps due to that book, WHO, the World Health Organization, invited us to write a recommendation, to do a search and write recommendations and guidelines for IUI, which we did, and I will show you a few of the results. These were the PICO questions. I will talk about all those questions in red in due time. First of all, if you go to that paper, there is a flow chart which is very interesting. The thing most people will not understand is the Huneau score. It's popular in the Netherlands, in Belgium. It's a score which was published many years ago, and it's looking at the female age, the duration of infertility, previous pregnancy not or well, referred by the gynecologist, which is specifically for the Netherlands, and the percentage of progressive motile sperm. And then you have a calculated probability of spontaneous ongoing pregnancy within 1 year. If it's more than 30%, then they advise the couples to not to go for treatment and expected management for 6 to 12 months. And you see also in the flow chart that how you can prevent multiple pregnancies, when you have to do it in male infertility, and so on and so on. It's a very nice flow chart if you want to start with an IUI program or you want to follow up according to evidence-based data. The first PICO question, what to do with ovarian stimulation. We all know, and I'm a referee of many papers on IUI, if the success rate is above 15%, you always have to ask them, what is the multiple pregnancy rate? Because there's always a link between the number of oocytes and the increasing success, and of course, the problem of multiple pregnancies. We know, and this is according to the literature, that ovarian stimulation is effective in unexplained infertility and mild male factor. That means a total motile count before washing of more than 10 million. And it's also ineffective in cervical factor infertility and moderate male factor. This was we found in a search and based on evidence. What about the male factor? Very difficult. What's clear, you cannot define a clear cutoff value for pre-wash or post-wash sperm parameters below which IUI cannot be done. If you look at the literature, the thresholds which are commonly found is sperm morphology using strict criteria of more than 4%, the inseminating motile count after washing more than 1 million, the total motile sperm count of more than 5 million, and total motility in the native sample of more than 30%. This is most common, but there is no evidence that this is the real threshold, of course. We will talk about IMC later on. One of the most important factors considering success after IUI is probably timing, rather too soon than too late. The first question was, if you use ACG, then it seems that you have to do your IUI between 24 and 40 hours after ACG injection. If you count on LH search in urine, you perform your IUI 1 day after LH rise. This is proven in many. One insemination or two. There is a meta-analysis that showed us that in case of moderate male infertility, two inseminations might be beneficial, but at the end, for unexplained, it's surely not. And our conclusion was women undergoing IUI should be offered a single insemination. It might be that studies are coming on with male infertility that you collect a few semen samples and put them all together, or you do two semen samples in the same cycle or in the same. That's what we have to find out in the future. But up to now, I think one IUI per cycle is more than enough. What about bed rest? There were two very good studies from Custis and Saleo showed us that the success rate is significantly better with bed rest. But then the Dutchman came again, and always the same story. They found in a very good study that immobilization or mobilization after IUI, they didn't see a difference. Even they saw a better pregnancy rate after no immobilization. This, up to now, with a recent meta-analysis, we still believe that 10 to 15 minutes of bed rest is good for success rate. It will increase your success rates. Semen preparation techniques, many studies published, but I think the Cochrane database, which was published in 2019, showed us once again that according to the available evidence, there is no specific semen preparation technique which is better than the others. Of course, there are novel sperm selection methods coming on, showing promising results, but we still wait for good studies to make sure that this indeed will help us in the future. What about BMI? Just to tell you, everybody thinks that if you have a high BMI, success rate is not good. We know from studies in IUI and many studies that up to BMI of 30, success rate are as good as what you expect with lower BMI. What we know is with a high BMI that you need more gonadotropins if you use ovarian stimulation. But of course, we still have to recommend people to have a normal BMI for obstetric reasons. And that's the only reason. But for considering success rate, BMI is not a real problem. What is the problem for the future? If you are IUI adept as I am, we have an increasing success in IVF-related procedures, for sure. There's increasing ongoing pregnancy rate, live birth rate, implantation rate due to better quality control, better labs, and so on. And adding that, there are less complications. That's what we always argued. There are more complications, but we have a lower multiple pregnancy rate thanks to the single embryo transfer, and we have less complications thanks to the antagonist, less ovarian hyperstimulation syndrome. And we have increasing success in cryothawing thanks to vitrification. This we have a problem with IUI. We cannot compete anymore. And I think if we don't do anything about that, if we cannot increase IUI success, I think the competition is over and IVF will take over. But we can do something about it. And I will tell you what we can do. There are some procedure-related things we can do. The interval between semen delivery and IUI, slow release IUI. I will give you some figures. The indication, we can, if somebody is too old, go to IVF. If the IMC is not perfect, go to IVF. If there is HPV positive for male and women, I think IUI is not the best solution. And of course also the age for female and male and the unilateral tubal factor. I will give you the details right now. First of all, this was a study from the group in Antwerp, and they showed, and there are other studies also, that if you do your IUI quite fast and not too long with interval between the delivery of the sperm and the insemination, that the results are significantly better. There are a few papers, and there is a recent one on slow release insemination with better results. This is a commercial thing, and it takes 2 hours, and it takes quite long, but it does help. And there is a study, a very good study. They showed that for women less than 35 years, there is significantly higher success with slow release insemination but of course, then you need that device. And what we did in Genk, and it was not because we were thinking about better results with slow insemination. All of a sudden, between July 2011 and 2018, we did a prospective study, cohort study. And from 2016 on, we changed only one parameter. Before 2016, all inseminations were done by MDs, doctors, fellows, or gynecologists, always a bit in a hurry, always bolus injection less than 5 to 10 seconds, and they left and so on. This was not the very good thing, but we had good results. We were very happy about the results because the problem of time, the midwives asked us, can't we do the insemination from 2016 on? They were, of course, they knew the patients much better. They were not time limited. It was a more patient-centered approach, and we told them and we learned them how to do insemination in at least 45 seconds to 1 minute. They sing a song in their head, and this is how we learned them. And we didn't expect anything. But all of a sudden, we saw the next few years that there was an increase in success rate of about 4% for the homologous insemination and also for the donor insemination, only changing the fact that we went from bolus injection to slow release, and slow release 45 seconds to 1 minute, and of course a patient-centered approach. We don't know yet what is really the benefit. And you see, it was significant for the homologous partner semen. It was the same increase, but not significant for donor semen. But we were quite happy, and we go on, of course. But it shows you that only by changing minimal things you can increase your success rate. And then the IMC, but in the same prospective study we found out, and it was Annelies Thijssen, her PhD, who wrote it, and that we had the best results with an inseminating motile count after washing between 5 and 10 million. And I think the optimum was about 6.7 million. And then there was also a study, a large retrospective analysis, Flemens et al. From the Netherlands, and they also found that 5 to 10 million was the best inseminating motile count for IUI with the best success rate. And there is a study coming on in fertile sterile. It's a very recent retrospective analysis of almost 80,000 IUIs. And you can see that they found better results from the moment on. You have at least 2 million, the results become better, and they advise to do insemination above 9 million. We have also recent results now in our center, and I think that 5 million is probably a threshold, but we still have to prove that. But 1 million, the 1 million we always promoted, is probably too low, especially because success rates with IVF are still increasing, and we have to compete with them. That's otherwise everybody goes to IVF. The male age, we know that the paternal age doesn't have an effect on IUI success as long as the female part is less than 35. But from the moment on the part is more than 35, the male age is important, and you have to take into account this when you put your indication for IUI, whether or not to perform. Then there are a few studies that show that if you have a distal tubal block, that the success rate with IUI is too low and significantly lower. This I don't recommend IUI in case of unilateral tubal distal block. And then the story of HPV, a few words about that. We investigated a few years ago together with the group in Antwerp that women with HPV positivity, and we looked at the success rate with IUI, and it was a bit of a surprise. We found that the clinical pregnancy rate was less than 2% in HPV positive women compared to more than 11% in HPV negative women. And in most cases, it was the infectious part of the HPV and not the clonal. The clonal form is the one who is responsible for cancer, but it's the infectious part of HPV, which can be important. And then we did a prospective study on a male, multi-center study, also a lot of IUI cycles, and we saw that the prevalence of HPV positivity of male was 12%. Around the world is between 10 and 15% per cycle. And the clinical pregnancy rate was only 2.9 for HPV positive men and 11% for HPV negative men. And above a ratio of 0.66 variants per spermatozoa, we didn't find a pregnancy. And if we looked at the donor inseminations with HPV positivity, we didn't have one pregnancy. It means it's very important for sperm donor banks that they look for HPV. Otherwise, we do a lot of inseminations without any chance of success. Can we do anything? Is there a possibility that if you know that it can clear after 6 months to 1 year, almost 90% of HPV positivity will disappear? We can tell people to wait. It depends on the age, of course, of the female. But is ICSI or IVF a solution? We don't know. We still need prospective studies to show that IVF or ICSI is a possibility. According to this study of an Italian group of Garola and co-workers, even for ICSI, they found a lower cumulative pregnancy rate in HPV positive men and also a higher miscarriage rate. And they also found a link with DNA fragmentation, which is probably the following problem we will face. What can we do about it? There are studies that if you give males who are positive of vaccination, that it improves the clearance of the semen infection. We can think about sperm processing, but up to now there is no good sperm processing technique which can avoid HPV transmission and success rates in IUI. What are the take-home messages? I think there is not one single predictor of how to predict IUI success. If you do a well-timed and slow-release IUI using ovarian stimulation when indicated, especially unexplained, in a well-selected population, which is not too old, female not too old, with no the distal tubal block, with adequate semen sperm parameters, for at least 3 cycles, I think it can result in a cumulative pregnancy rate which is comparable with IVF and ICSI. And don't forget, some people like it. IUI is cheap, it's non-invasive, it's safe, at least if you can avoid the multiples, and it's patient friendly. And this is where I want to stop. Thank you so much.
Thank you so much, Professor, for your incredible talk. And now if I can ask you a question, what do you think the correlation is between countries that have high ICSI and low IUI rates?
I think it's all about reimbursement as well. For example, in Belgium, there's reimbursement of IUI and IVF, and then people they don't blame you starting with IUI. From the moment on, you have to pay a lot also for IUI, and you see the success rate is only 6-7%. You always go for the best. But it all depends on reimbursement policy and the fact that there is still the belief that IUI always gets much more multiple pregnancies, but we can avoid it.
Amazing. Thank you so much, sir.
Thank you.
And now I would like to introduce our next presenter, Elena Lenara Demakaku. Elena is an embryology manager at the London Women's Clinic, Harley Street. She has 15 years experience in the field of reproductive medicine and has played key roles not only in the daily embryology practice, but also in regulatory compliance and quality management within the group. Elena is an experienced senior embryologist, a diplomat of the Royal College of Pathologists, and a member of ARCS and ESHRA. She works hard to ensure the success rates, but above all, best care and service to patients. She strongly believes in the individualized medicine, and she has special interest in embryo morphokinetics and prenatal genetics. She's highly engaged with research and has presented her work in both national and international meetings. She is the STP lead for London Women's Clinic and has been one of the first private IVF labs that gained a license from NSHCAs to train SCP trainees for reproductive medicine.
Thank you very much, Jermita, and thank you very much for the invitation. I really want to start by saying congratulations for this great platform that has held us together throughout the pandemic, and it continues to keep us engaged with our profession. I'm very happy to be here. Today, I will be presenting a study that we've recently published at the Reproductive Biomedicine Online, that outlines the cumulative live birth rates following donor insemination. I have no conflict of interest other than, as I said, I'm working for the London Women's Clinic, and this data arose from our patients, and it is published at our BMO. I would like to start by saying that artificial insemination is a very simple form of treatment that has been widely used worldwide. It is non-invasive, and in certain cases, it can also be cost-effective. However, its overall effectiveness and its general success really has been several times questioned. And if I may say, it has also been threatened from time to time. For instance, advances in technology and the introduction of ICSI has created an interesting interplay and has sort of caused a pause in its uptake. As you can see here, for instance, in figure 1, you can see that since the introduction of ICSI, we have a beautiful, great increase for ICSI treatments, but at the same time, we have a parallel precipitous decline on IUI. And these data are coming from the HFEA register. In addition to advances in technology, we also had landmark changes in UK regulation that has also created a little bit of a pause on the uptake of donor inseminations. And for example, the removal of donor anonymity that occurred in April 2005 gave, on one hand, the opportunity to donor-conceived children to be able to trace their biological fathers once they reach the age of 18. However, at the same time, they have created a lot of anxiety and rumors that sperm donor treatment will decline. However, quite the contrary occurred because, as you can see here in figure 3, there has been a significant rise in sperm donor registrations. And you can also see that it was almost quadrupled between 2004 to 2016. This increase in sperm donor availability created a significant influx of donor inseminations for us at our clinic and gave us the opportunity to collect a really wonderful cohort. A cohort that we wanted to analyze, not only to see the effect of law in clinical practice, but most importantly, to try and answer a very debatable but also very important question. And that is whether IUI is an efficient treatment. So let's go to see, based on our study, is it really a successful treatment? Our study was a retrospective analysis of 13 years of donor insemination. It includes a period of 2004 to 2016, and it analyzed 3,333 women that underwent 8,922 consecutive donor inseminations. 58% of the cycles were natural, while 42% were stimulated. 45% of our women were single, 43% were same-sex, and 12% were heterosexual. We ended up with 795 live births. 3% of them were twins, and I believe we had also one triplet, which is a low multiple pregnancy rate, which is equally important equally important as the success. We decided to study 3 main factors and their relationship with the outcome. And these factors were patient's age, ovarian stimulation, and relationship status. Our main outcome was live birth rate. And in particular, we wanted to look at cumulative live birth rates because we believe that they could give a better prognosis, but also better patient management. If I start by looking at the age as a factor, I mean, it is a very well-known factor that as the age is increasing, the chances of success in any fertility treatment really is decreasing. And it is exactly what we have also seen here. we can clearly see a clear decrease of success with advancing age, which is well expected. So we can see that, for example, patients under the age of 35, they have an approximate live birth rate of 13%, whereas as you're reaching the age of 40 to 42, this drops to 5%. And if you are 43 and above, it goes around 0.4%. Then we wanted to see as to how stimulation actually affects the outcome. And as we can see, stimulated cycles were performing a lot better than natural in most of the groups, but in particularly, it was statistically significant difference at the age group of under 35 and also the 40 to 42 years old. Moving to the relationship status, we can see that there was a little bit of a difference. When we've looked at 4,238 cycles of women that they were in same-sex relationship, we had a live birth rate of 11%. For heterosexual couples, we had 10% live birth rate, and then for singles, it was dropping down to 6.7%. And even if this looks interesting, if you look on the table on the last column, you can see that the mean age of the patients in each group was different. So really, if you compare same-sex couples with single women, you can see there that single women were a lot older. And therefore, this to me shows that the association is clearly confounded by age and not the relationship status per se. We then moved on. We wanted to go a little bit deeper and do a multivariate analysis just to identify some probabilities. What we have seen yet again, that female age and ovarian stimulation were significant factors. The relationship status was not playing any significant case here. But what was interesting to see was that the patients that they have had previous live birth with IUI, they had more than double the probability, the chance to have a live birth with the next attempt. When we talk to patients, we really want to be able to inform them of their chance to take home a baby. And many times they especially want to know what their probability is to have a baby after a defined number of cycles. We therefore decided to calculate cumulative live birth rates, as we felt that this would be much more meaningful prognostically, but also better for their management. As you can see here, when we plotted our cumulative birth rates by age, we can see that first and above all, we have acceptable cumulative live birth rates across all groups. However, what is really evident, and for us very interesting, is that there is a very clear plateau effect that starts at the 6 cycles onwards, which tell us that really there is little or no additional benefit after the 6th cycle. And if you look at the yellow line, you can see that for older group patients, for example, between the 40 to 42, you can see that there is no real additional benefit after 3 to 4 attempts. When we compared our results with the literature, we have seen that some of them have had higher live birth rates and higher cumulative live birth rates. However, there were several differences in these papers. For example, some of them, they have had a lot smaller sample size. They had a lot younger patients involved. Their methodologies were different, and also they were doing a lot more stimulation cycles than natural, which was the opposite from us. But on top of this, something that we identified in our study and was interesting was the dropout rates. Patients can drop out from IUI for so many different reasons. It can be totally multifactorial, and it could be because they want to go for IVF, they're changing clinics, they're changing their mind. It could be financially related. There are really so many things. However, we wanted to take this into account and try to recalculate our live birth rates, assuming that there was no really dropout. If that was the case, what would we expect to see? And as you can see here, when we replotted it, we had significantly better outcomes, which was indeed very reassuring. I would like, though, to go back to the original cumulative live birth rates, because for me, this is what is most important. And it's interesting to see that is in direct contrast with the guidelines that we receive from NICE. For example, the NICE guidelines, they suggest that for patients that they don't have significant medical history to note, we should offer up to 12 IUI cycles prior to consider any IVF. For patients with unexplained infertility, mild endometriosis, or mild male factor infertility, they don't suggest offering routinely IUI at all, but rather suggesting them to try to conceive for a total of 2 years before switching to IVF. As you can imagine, the NICE guidelines have been fiercely criticized, as they can be very controversial, and there have been several colleagues, health professionals, that they really don't necessarily follow that or believe it. Now, what we believe, though, is that there is significant value on the sample size of our study, and the follow-up of the consecutive cycles of 13 years. And this gives us the confidence, really, to confirm that our data, our results, are more generalizable, and they can be applicable to the population, even if we have to consider that they were undertaken in a private setting. We can therefore conclude that no more 6 treatment cycles are reasonable for women when they are under 40 years of age, that there is no additional benefit. 3 attempts of IUIs can be reasonable for the ages up to 42. Donor IUI definitely performs better in stimulated cycles than natural. And finally, acceptable cumulative live birth rates can be achieved after a certain number of cycles in a similar population to our cohort. So thank you very much for listening.
Thank you very much, Dr. Linara Demakaku. That was terrific. Both your presentation and Dr. Ombelet's were just terrific work. And I wonder if I could ask you a question before we open up the Q&A session, which I look forward to. We have a question here from the audience. It is from someone named Galal Abdo, and they're asking, how do you calculate a cumulative pregnancy rate for IUI?
So we're calculating by using a method whereby we are having the number of cycles, and we're keeping all of our cycles together. So our denominator basically is the number of cycles, and as we're going per attempt, we're basically adding on our numerator the extra number of live births.
So your denominator is the number of cycles in your clinic that they're doing IUI before they drop out.
Correct.
So it's just the total. So
Correct.
Everyone has a different denominator.
No, the denominator is always the same. So we're starting with 8,922 cycles, and it's all the way like that.
Gotcha.
And then what you do in your first attempt, for example, you have 10 live births, so that will be 10 over 8,922. By the third attempt, you will have 30 live births, so it will be 30 divided by 8,922. What can be confusing for the audience was our recalculation for expected, our crude live birth rate. That we did it purely because we wanted to show how important the dropout rate is.
Thank you. That's very clear. So I'd like to invite the speakers, and of course, Jermita is on camera, to go on camera and to unmute themselves so we can have a chat. And I want to just say I'm very happy that this forum is discussing IUI at all. I think it's terrific that we're actually talking about it today because I also believe there's a place for it. Dramita, did you want to ask a question, or if anybody else wants to ask a question?
Yes. So this question is for Professor Omelette, and it's from Tracy Fletcher, and she's a laboratory director at PCRM, Victoria Fertility Clinic. And she asks, should IUIs be performed the same day as the reported LH surge, or on the day after the reported LH surge?
The day after. If you do an LH search in urine or blood, you do the insemination day after. Probably even if you do it a bit earlier, it doesn't matter that much, but that's the best option.
Thank you.
We have a question from the UK, Guidry Lopez. What is the ideal temperature for preparing and storing IUI sperm samples before the procedure? Elena, do you want to take that one?
We don't do room temperature. We're putting them at the incubator after process.
Oh, you're doing them at 37 degrees? Okay, so not at room. How about you?
We are preparing at room temperature, and then after preparation, we put them at 37 degrees.
Yeah.
Okay.
We do the same. I think room temperature is okay. You have less oxidative stress in your sperm sample if you put it on room temperature. I think we do just the same.
I was interested in something that Professor Omelette said about the HPV. The HPV data was fantastic, really great. And I wonder if you have any comment on the double tube method that is sold by Nidacon. It's the double tube method to reduce seminal products from ending up in the final pellet. And we use that for samples that we fear may have some virus in the seminal fluid. Are you familiar with that?
We are not familiar with that, but I know about different methods. They tried everything for HPV up to now. None of those studies are convincing. It's still a big market, you know. And the problem with HPV is why it's not commonly known is that HPV disappears. You can have HPV and then 3 months later they become pregnant and you think, oh, she was HPV positive. It disappears after a while. The only message we want to give is if you have an HPV positive male or female, and if it's a female, it must be the infectious one, not the clonal one, but the clonal one is the one who gives cancer. But those people get pregnant easily, but those with the infectious form, they get not pregnant up to the time that it disappears. And there is a lot of work to do because the studies are very contradictory, and the main reason for female infertility is that they put together the female with the clonal one, which is not important for infertility, and the one which is important for infertility, and this is they study the population which is biased by the clonal ones. But what we found out the last few years is from the moment on that you have HPV positivity, higher miscarriage rates, higher lower success rate, and the problem is what to do about it. And we need studies now to find out, prospective studies, if IVF is a solution, if ICSI is a solution, if vaccination just before the sample is a solution, if cryopreservation of the cervix is a solution for female HPV positivity, and so on. There are different studies we want to do. We want to start with a PhD on that one. But still up to now, a lot of people don't believe it's true. And I think you must imagine 12 to 14% of people are positive at the moment they start with IUI or IVF or ICSI. And from female, it's almost the same. And we saw that if the female is positive and the male is positive, we almost never had a pregnancy. But we don't know about it. It's always unexplained infertility. If we have better indications for IUI, the success rate per IUI will be better, of course. And then we can compete with IVF again.
Did you say something about cryopreserving the cervix?
I think if there is a lot of variance on the cervix uteri. If you put in your catheter, you put in the variance in the uterus. It might be that if we cryopreserve if we do or coagulation, we diminish the number of variants, going into the uterus with female HPV positivity. But it's all ideas. We didn't try it out. We have to start. And there are a lot of people listening now. You can do that. I think there is something to say about it. Another problem is, of course, making the diagnosis. It's in some countries it's expensive, and it's not an easy one.
No, go ahead, Jamita. Sorry.
So I have a question from Joan Garcia, and she asks, do you use multiple sperm samples for those with very low sperm to be inseminated? At our clinic, if our total modal inseminated after the wash is less than 5 million total modal, then we will go ahead and thaw a second pile. What does anybody else think?
There are not so many studies. There are studies trying out to find if you have less than 5 million, you ask for a second sample or a third sample, and you reach 5 million. But the studies I saw, but some of them are not published yet, they couldn't find a big benefit of it. And we don't know about the IMC yet. I think it's still a bit, that we need more studies. What we found in the biggest retrospective analysis, it's always retrospective, that possibly the threshold of 1 million is too low, was good enough 20 years ago when you compared with IVF results of 20%, 15%. But nowadays, the results of IVF are so good that I believe that IUI, you can perform it if you have at least 5 million IMC. That's probably the threshold we are looking for in the future, but still has to be proven.
Yeah, that was a very useful takeaway from your talk, the 5 million. That was great. And I do think
I was always the one who defended 1 million.
Yeah, but you had to modify that. I saw your data. That's right. I mean, we've all seen pregnancies at 1 million or even lower, but those are unicorns, right? They're not very common. But the 5 million is a great rule of thumb. And I think that the audience will really appreciate hearing that from you. Elena, there's a question about your study design, that one of your filters was relationship status. Now, I understand you presented your data and showed that really that was not a confounding factor, but it was something that you use to identify as, as a group. And that's of interest. I think one of the audience members from the UK, Anna McLaughlin, is asking that question. Can you address that for us?
Yes, of course, of course. I mean, there are several things why we have chosen to do relationship status. The first thing is that we as a clinic, we are known to have a high percentage of patients for many years that they're same-sex or single women, due to the fact that we were having good availability of donor sperm. Okay, so that's one thing. So I wanted to see when I look at same-sex and single and heterosexual, see if there is any difference. This is one thing. So I had the ability to do it because of the cohort. But the second thing is that I feel that apart from the actual clinical factors and medical history in any patient, for me, social factors are equally important because I was trying to see how the relationship can actually affect the outcome. When a single woman who is not only necessarily a little bit older is going through lots of things by herself, I wanted to see what's happening when they're having a partner. So more of a sociological input there to try and see. And I was very happy that we have been able to identify these patients in our cohort.
Your cohort is so impressive. It's gigantic. And so that was one of the questions from the audience, is how your cohort was so huge. And it's because you have access to donor sperm, and that attracted the patients.
Definitely. I mean, we do have the biggest sperm bank in the UK, so that was one thing. But also, since the removal of anonymity, there have been so many things that they have been happening. I think that we have been able to import sperm from abroad. The donors have changed totally the way that they're thinking, and they're a lot more open to the fact that anonymity was an obstacle before. Since 2012, there has been another change in regulation, for example, that allows donors to be paid for some expenses for their traveling, for example, to come to the clinic. So this has given us this really beautiful cohort.
So are you satisfied from your study that relationship status does not impinge, it's not an independent indicator of success?
Yeah, I mean,
Okay.
when you're doing a statistical analysis, obviously the confounding factors that are so strong are mainly clinical. And therefore it's very difficult to really bypass that. So
So you still say there's a role for the socioeconomic impact on their success?
for me, socioeconomic position, social factors are important, maybe not equally important, but when we have the opportunity to study them, I think it's worth it.
Very good. Go ahead, Jamita, sorry.
No problem. I thought it was really interesting. So I have another audience question. Do you think that the handling of the transfer catheter and placement of the sample into the uterus makes a difference? Kind of like how how an embryo transfer technique it matters there.
There are studies showing that there is no benefit of ultrasound guided insemination. It's not the same as in IVF. But I cannot I want to show, I showed that slow insemination is probably the solution. We always did it in most places on earth. They do an insemination within 5 to 10 seconds. That's a bolus injection. And the fact that we had such an increase in success only by performing them in 45 seconds to 1 minute, it might be that if you do it in 5 minutes, the results are even better. This slow release is probably much better and much more successful than how to do it. Of course, it's always better to do the right thing and to do the soft way, but probably the slow release is more important than how to put in your catheter.
So it's the 5 million and it's the up 45 second to 1 minute release. Those are the keys for improving your outcomes with IUI. Would you say that's fair?
No, and good indication. Those you know will not become pregnant. HPV positivity, unilateral tubal factor. This changing the indications, the female age. We were happy years ago with 5 to 6% per cycle for women above 38, but now we are not happy with that anymore because the success with IVF is better. Because I think we have to go for better indications, stricter indications, and then slow insemination with at least 2 or 5 million motile spermatozoa.
So Elena, I wanted to ask you, because of the donor pool that you have, would you recommend IUI for autologous, or would you send them to IVF? Would you think IUI should just be donor?
Can you just repeat the question, please?
I'm sorry, with your donor, you have such donor sperm availability in your clinic. Do you recommend donor sperm IUI preferentially, and couples who are autologous and not using donor sperm, do you think there's a place for them? Because I know the rates drop dramatically above the age of 42, for example, and there may be more benefit, as Dr. Ombalet said, to go straight to IVF at that point. I just wondered what your thought was.
I think that there are so many factors that we have to consider when we're offering treatment to a patient. So, for example, we have to look at all the clinical picture of a woman, for instance, before we are able to say, irrespective of whether she's using donor or partner sperm. So we have to look at her age, and we have to look at how old she is, what's the medical history. If there is enough time for a woman not to miss the train, really, then absolutely, I don't see a reason why we cannot go ahead for IUI, as long as I said, anatomically, clinically, everything is absolutely fine. But of course, if there are other issues, we don't want to compromise her success, and we should convert to IVF.
So maybe a 42-year-old is going to miss the train, but the 32-year-old won't miss the train.
Indeed.
Right.
But don't forget that for partner semen, the success drops after 3 to 4 cycles.
Yes.
With donor semen, it's different. Then it's no drop after 6 cycles. It's totally different. You have a better success rate, and you can go on for a longer time.
So that's great. And that brings me to my next thing, is these guidelines. These are very controversial. I wanted to ask you both, and I'm sure Jamita, we wanted to know what your thoughts are. Obviously, 12 cycles, my goodness. Is there any hope that these can be modified, or refined in some way so that they're applied properly?
But I remember when the NICE guidelines came out, I gave a lecture in London, and I asked them what happened, because this was ridiculous. It was no evidence based, and they put a lot of energy and a lot of money in it. And then they told me, yeah, but we heard that the success rate in England is in UK is only 5% per cycle and so on. I told them, come to Belgium, we'll learn you how to do IUI. But I think the NICE guidelines were based on the wrong data. And everybody was, and I looked at the figures and at the study who performed the IUI afterwards in the UK. 90% didn't care about the NICE guidelines. 90% of centers, they didn't care, and they went on with what they did before. I think the evidence for the NICE guidelines considering IUI were not good.
Elena, what are your thoughts? Yeah.
Yeah, absolutely. I would agree. Again, every treatment, every patient has to be treated individually. And these guidelines are causing an issue not only in terms of patient management, but I mean, I'm working in a private setting, but NHS, the public setting has been really having issues with this. And this is why it's receiving criticism, because funding is related to these guidelines. So we have to be very careful, very, very careful. And as Professor Williams said, I mean, the background of these guidelines is not necessarily very strong.
Yeah, and if you talk about 5% success rate per IUI, then of course you can't do IUI as a first line treatment. Then you go on and expect that management is the best solution. But even in those years, success rates in most Western Europe countries was between 9 and 13%, which is totally different. And of course, take into account that a lot of patients want to have a less aggressive technique before they start with IVF. And they get used to the center, they get used to the doctors, to the people. And it's I think from a psychological point of view, it's a good first line treatment in selected cases.
I completely agree. And I think socioeconomically, there's a real place for this. We've tried to go to InvoCell, which is, the vaginal culture system for perhaps low socioeconomic status patients. But I think IUI, as long as they have open tubes, and as you say, we've indicated correctly what the candidates should have and not have, I think there's a place for it. We did a prospective study. It was published in 2019 in JARG, looking at additives to the seminal plasma, seminal fluid, to improve motility. And I think, so I wanted to ask about, testing like DNA fragmentation and those sorts of things in the context of IUI. Do you have any comment on whether these add-on tests have any place?
Yeah, there were a lot of stuff they used, and none of those studies was really convincing. We have the impression now with our studies we do on HPV that the DNA fragmentation index will probably become more and more important. I didn't show the figure, but we have a study which was recently published a few months ago, where we found that if you have a DNA fragmentation index of above 26%, almost no pregnancies. What can you do about it? We don't know. You can give antioxidants, but we don't know. It can take a long time. And that's the problem with HPV and DFI, what are you going to do if it's positive? And we know that an increased DNA fragmentation index is also linked to more miscarriages. But I really believe that from a sperm point of view, I think DFI will be an important factor in the future.
Lena, I have a question for you, and it's from Sabina Sahid. When ordering donor samples, do you recommend or prefer MOLT10 versus MOLT20 samples for IUI?
We do recommend MOT10 and above for IUI, just to ensure that we have enough sample there to work with. Because again, we are having the 5 million rule for total insemination count.
Do you see a difference in pregnancy rates for patients that have 20% thin? Because I know it's due to price most of the time.
I don't have this data so that I can tell you, but it's difficult. Empirically, I would say that it really depends on how well the semen sample performs when you put it through gradient and washing.
Can I ask about your procedure for sperm washing?
Mm-hmm. So we are putting through gradient 80% and 40%, and then we centrifuge, and then after centrifugation we double wash, and then we put it at 37 degrees in an incubator and then inseminate. We're trying to do this approximately 2 hours before we perform the IUI.
And how long do you put it in 37 degrees?
After the whole preparation, it will be maybe less than an hour.
Yeah, that's pretty much our protocol as well. And I know when come back to fragmentation, there are some devices now that are commercially available, but I don't know that they're indicated for IUI use. They're for IVF.
Yeah, most of the time they didn't do studies on IUI.
That's correct.
They are asking us to do the studies, but we, at this time, the ethical committees, they are so difficult nowadays that it's becoming frustrating.
You mean the
But
IRBs in
not
order
so many
to,
studies
yeah.
are done on IUI. I think we have to do them. And you mentioned the Info system as a low cost. We have the Van Blercom system in our center, and it's almost ready. It's even cheaper with extraordinary results. We have now 200 babies born, which are even better than what you normally expect with IVF and IUI. There is something coming on considering low cost RT, I can assure you.
That's terrific. We're moving the needle forward on IUI. It's not just stalled. Can I ask you?
There will be an in-between between IUI and regular IVF ICSI. And the in-between will be the Info system and will be our system. This is what I predict for the future.
Right. Can I ask you, what is the Walking Egg Project? Can you tell us what that is?
The Walking Egg Project is, the aim is to make infertility care affordable or accessible for a much larger part of the world population. Is not only the techniques itself, but also the diagnostic procedures, everything what's linked to infertility care, make it more accessible. And this we focus on a very low cost diagnostic procedures, looking for semen samples. You can do it now with your iPhone. You can do so many things very cheap. Then we mild stimulation protocols from the ISMAR group. We all know that. And then we are almost finalizing a ready to use very cheap IVF product and a system. And this will change. I hope this will change everything for the rest of the world, because we always think it will become cheaper. What I saw during the last 10, 20 years, that the price always goes up. They never go down. Yes, we were talking about 8,000 euro in the States 20 years ago. Now we are talking about 12,000 to 15,000. And the success rate we have with our simple system, and it's so easy. It's comparable with IVF and ICSI, and even with moderate male infertility, with good babies. This I think, but I'm not sure we will be successful. Most people don't like it. Of course, you can imagine that the commercial companies and some lobbies don't like it, but it's very difficult to publish these data, I can assure you.
I can't even imagine. And I think it's terrific that you're trying to persist with this and create this, whole new pathway for patients. I think it's unfair that everything always goes up. It's true. And you're absolutely right. Nothing ever gets cheaper. It's terrible. So I do applaud that. And Elena, I think your data's amazing. You presented such lovely data. The graphs were terrific. It's very compelling. And the data sounds exactly right in terms of the confounders and the selection of patients, the processing of the sperm. This is very valuable, I'm sure, for the entire audience. Thank you both very, very much. Jamita, do you want to take it from here?
Yes. Again, I would like to thank all of the panelists for joining us today. Again, and I would also like to thank all of everybody who's joining us. I would like to thank you for taking the time to come to our webinar and to be a part of this discussion. I would like to thank the I3 speakers, William Omblet, Elena, and of course, my co-host, Dr. Jindal. I would also like to thank the organizing committee of this initiative, Jack Cohen, Peter Nagy, Giles Palmer, Thomas Elliott, and Shyster Sadruin, and Allison Bartolucci, and today's Q&A team.
Thank you, Jermita. And this session and presentations will be available on the website soon. And don't forget to rate our lectures. That's very easy to do. Your certificate of attendance will be sent before the commencement of our next session. So let me tell you about our next session, which is next Tuesday, as always, at 3 p.m. CET, 8 p.m. in the UK, and 3 p.m. Eastern Standard Time, I'm sorry, 9 p.m. CET. The next session is a session designed by our own Liesl Nell Thamat. It's all about transgenics, clones, and animal reproduction. Giants in the world of animal reproduction, Dr. Martha Gomez, Professor Richard Beringer, Dr. Hiroshi Kiyonari, and they will all speak on species recovery strategies and conservation in Therio 2. I think that's it. We can wrap up our session today. I will send you to our website, the I3 website, and I want to thank all the organizers again and our speakers. Just wonderful presentations today. Thank you all. Thank you all for attending. Bye-bye.